होती है तो हर कोई बस चाहता है डॉक्टर जय मेहता का साथ। रीडू सर्जरी, फिस्टुलास, वजानोप्लास्टी या आईवीएफ फेलियर का करना हो सक्सेसफुली ट्रीट, तो डॉक्टर जय मेहता को आकर कर लो मीट। So today I present to you Dr. Jay Mehta. He will be speaking to us on lymphocyte immunization therapy. Over to you, Doctor.
Nice poetry, but thank you. So we'll come straight to the point. See, first of all, lymphocyte immunization therapy. Here on, I'll just address it as LIT or PLIT because it is paternal lymphocyte immunization therapy. Instead of paternal, it can also be male partner in some countries. Okay. Let me please tell you, this is not something which has been started by any one of us. This has been something which has been mentioned and studied going on since probably 25 to 30 years or probably before that. And I think myself and Dr. Shilpa were once having a discussion, and she mentioned to me that a fertility unit in Bangalore, I think I forgot the name, but the fertility unit in Bangalore was doing it since almost 25 years. If my memory is right, I think it was Dr. Gunshila's fertility unit in Bangalore, but I could be wrong. Okay. So that's what I was told, that madam was doing that since almost 25 to 30 years. So it is something which has been being practiced in India also since quite some time. Obviously, then for a very long period of time, it went out of focus. And after that, now again, since the last 5 years or so, it is something which has come back into existence. And probably we can call it as something which is extremely well marketed. Because one thing is for clear, okay, despite everything what we do and despite all the meta-analysis and all these things which have been published regarding this, there are people who are saying it is going to have either unclear benefit, and there are some people who are going to say that no, definitely there is some or the other benefit, right? If there is a single take-home point, which people have to take home from this session, then the take-home point is that for sure, okay, and this is for, this is a no-brainer, okay, have the best possible case selection criteria when you want to do LIT, okay. So when I try to say have the best possible case selection criteria, okay, it is important that the patient has had recurrent spontaneous abortions, preferably of unknown origin. So that means idiopathic recurrent spontaneous abortion. This therapy will work the best if these abortions have happened in the first trimester. Less than 11 weeks is ideal. Less than 13 weeks, you can extrapolate. Okay. Most of the times in our country, abortions in the second trimester, okay, are going to be due to cervical incompetence. They are not going to be, we hardly see spontaneous expulsions in second trimester in our country. Okay, so be careful of that. You may choose to wisely eliminate second trimester abortions if your history taking is very good. Okay, this therapy is only to be used if all other male partner factors and female partner factors are normal. Okay, everything normal. This therapy will only benefit those couples who plan to have a child using own eggs and own sperms. Okay. See, in Bombay, we often see LIT being done for a couple who wants to have embryo adoption. Okay. There is no role. LIT has no role in embryo adoption. Okay. We often see in Bombay LIT being done for female partner who is opting for donor eggs. It has got no role. Please take home this point. This is to be advocated only to couples who have all parameters normal, male parameters normal, female parameters normal. Okay, so we are going to take you through a case which was referred to us from Bangalore. It is just yesterday, the patient was referred to us for LIT. And it's important to understand that the female partner had normal AMH. The female partner had normal routine menstrual cycles. the male partner had normal semen analysis, but it was reported that morphology is just 1%. Okay. So that is not normal. If morphology, normal forms are 1%, it is not normal. Okay. You need to repeat the morphological assessment. You need to repeat the DNA fragmentation index. If that is normal, female partner is also not normal because the tubes were not tested. So we had to test her tubes. And after all those parameters were concluded, we told them you don't need LIT because you have had one biochemical pregnancy and you have had one first trimester abortion, which is an anembryonic pregnancy at 7 weeks. Okay. This is not the criteria. See guys, वैसे हम जब when we try to discuss with each other and when we want to put each other down, we start shitting out RCOG criteria, no? That in RCOG criteria, you should have 3 abortions and only then you should investigate and this and that. है ना? तो ये criteria, actual indication of that criteria is here. Okay. Allow 2 spontaneous or 3 spontaneous abortions. Usually patients will listen to your counseling. And what is important is if you counsel them correctly, every year on an average, we end up doing close to 75 to 100 LITs for indicated patients. And every year we end up rejecting close to 500 patients for LIT. Then they will get convinced and they will go and get LIT done somewhere else, but it is not going to help them. That is for sure. We give it to them in writing. After following this strict criteria, okay, we think that LIT is probably going to help in around 15 to 20% of the cases only. It is not something where you have 100% case benefit also. Okay, because there are so many factors which are regarding to LIT but absolutely unknown to all of us. Okay, so with this introduction, I would just like to I think Pratima madam, I just want you to be unmuted because I would like to start the screen sharing. Okay.
Yes, yes.
So because once I share the screen, I can't see any one of you. Okay, so here we go. See, whenever I'll try to draw, I'll try to actually draw a uterus. Okay, this will really make life easy is what I think. Can everybody see this uterus, madam?
Yeah, the whiteboard is seen.
The whiteboard is seen. Okay, great. So inside this uterus, we have obviously the endometrium and we have the fetus. Sorry, I'm drawing it in cephalic presentation. Don't get angry on me. I understand early fetus can be in variable presentation. That much obstetrics even I am aware of. But what is the cause or postulated cause for these abortions? Okay. See, it is simple. You know, a fetus is actually a semi-allogenic product, no? It is basically a semi-allogenic product. Why is it semi-allogenic? Because a 50% contribution is going to come from male partner. Correct? 50% comes from mother. So this 50% mein to koi problem nahi hai. It is this 50% which actually comes from the male partner. Na? So how does the body's immunity react? So any time against this male partner products, if the body tries to secrete antibodies, okay, or just let's put it as a reaction, okay, the mother's immune system, which is absolutely normal, the mother's immune system will provide something called as blocking antibody. Okay, it will do it. It happens in all women who become pregnant and deliver. Okay, so it will provide this blocking antibody which takes care of this semi-allogenic product and it allows the fetus to grow. It obviously allows implantation to occur and it definitely prevents abortions. Okay, so it is believed that sometimes what happens is this blocking antibody is not correctly produced. Okay, this blocking antibody is not correctly produced, which is where the LIT therapy, that is lymphocyte immunization therapy, comes into factor. Very simple. Do not get into this theory of Th1 and Th2 helper cells and which ratio is increased and which ratio is decreased and all these things. It is not going to really help you for practical purposes. Okay, it is not going to help you. So do not get into any such type of mental headaches as to what is going to happen. So please understand this concept of blocking antibody first. All right. Now, once that concept is clear to everyone, the second thing which is important is how do you generate this artificially? How do you put these lymphocytes from the father, put them in the mother, and allow this to generate blocking antibodies? Okay. It's a very simple thing. See, everything is actually lymphocytes, no? Lymphocytes are the one who set up these reactions. Lymphocytes are the ones who cause production of IgG, IgM antibodies. Thoda bahut, if you study, then you will understand it is everything related to the lymphocytes. So what is important is once you have the Buffy coat is all the WBCs. WBCs के अंदर क्या आता है? WBCs has lymphocyte, अपना क्या बोलते हैं, neutrophils, all these things. Okay, all those things are present inside that small little Buffy coat. From that Buffy coat, you are supposed to separate lymphocytes. Okay, you are supposed to eliminate every other cell and only keep mononuclear cells. Lymphocyte is a mononuclear cell. This has been taught to me by my hematologist. Probably it was taught to me in pathology also, but definitely I've forgotten about it. It is only that when my hematologist started showing me the slides and actually forcing me to go through these slides, I started to understand why he's giving so much importance to this. Okay. So normally what the hematologist does is, even you can get trained in doing it. So it is not rocket science. Okay. They will take around what we do. I'll tell you. Definitely after all these criteria are established, definitely after that, before doing all these things, that viral screening, blood group, all that we will do, uske saath mein we will always do something called as CDC cross match. Simple, commonly available test at many pathology laboratories in more than 150 cities of India. Okay, so it is not something which happens in one small remote stupid corner of Bombay. It happens at many places. ठीक है, तो ऐसा कुछ है नहीं. Once the CDC cross match turns out to be negative, that means donor and recipient are not sensitized to each other. Correct? That means the maternal sensitization to the blood has not occurred. Only then LIT is to be performed. If the CDC cross matching is positive, that means blocking antibody is present. If blocking antibody is present, तुम्हारा LIT will not even do paplu work inside, because the body's reaction is way more strong than this artificial reaction which we are trying to introduce. So that is your second take home point. If CDC cross matching is positive, this therapy does not work. God has done the therapy for you. Understanding? God has done it. Okay. पुराने जमाने में we used to say ना, अभी तुम सब भगवान के हाथ में छोड़ दो after 5 abortions. Okay. Why? And some people would leave it to God and become pregnant. No. Why? Because God has performed that immunization, probably blocking antibodies developed, and everything went off well in the 6th pregnancy. Okay. Fine. Then how do you do this therapy? Very simple. Normally we ask the patient to have around 5 to 6 hours of fasting. Okay. Patient matlab husband. Okay. He has to be fasting. Wife can do whatever she wants. Wife can eat pizza and come. But husband has to be fasting for 5 to 6 hours. Why should the husband be fasting? Because it reduces the turbidity in the blood. Whenever somebody is fasting, the amount of triglycerides in the blood goes down temporarily. Okay. When the triglyceride level goes down, no, the blood is not very turbid. Again, this is not my input. This is completely taught to be I have the best hematologist in the city. Okay. Yogesh Bhai. So he's so good. He will go and make slide of everything which you give him. Okay. So he has taught this, that no, the patient should have 5 to 6 hours of fasting, husband. Okay. Then when the husband comes, even if the textbook says that you can take around 50 cc of blood, he normally takes around 80 cc of blood. Okay. He takes 80 cc of blood. After this 80 cc of blood is taken, there is a special tube which is available, which is called as Ficol's tube. I'll post photos of this tube. Very simple, commonly available. Again, not manufactured by us. We import it from Germany. You want a sasta version, it is available from China. Okay. Chinese version is also very good. We have used it 2-3 times, but we normally prefer the German version. Okay. It is also very good. Okay. So in that, there is a density gradient system which is present. This density gradient system will allow you to beautifully separate plasma, RBC, Buffy coat, and lymphocyte. Okay. So now there is a special technique which he applies based on the amount of blood parameters based on CBC, how much medium to take, how much gradient to take, how much this to take, all that he will calculate on his own. He is super brain, so he will calculate all these things on his own. He will pour the blood inside that, and then he will keep it for processing. After the processing is done, he will remove the lymphocytes from there. He will prepare a slide. He will study after staining that it is 100% lymphocytes. Okay. This 100% lymphocyte is then verified. The slide is given to the patient. KLA by tera PLIT ka slide. And from 80 cc blood which you take, the amount of lymphocytes which we are able to obtain is 0.3 to 0.4 ml. Very less amount of lymphocytes you will obtain. So again, the rule of hematology is, let's say you have 100 ml blood, only 1% will form buffy coat. That means only 1 ml will form buffy coat. In that 1 ml, around 40 to 60% will be lymphocytes. Okay. So that means if you take 100 ml blood, you will get maybe 0.4 to 0.5 ml of the alicot. Okay. So you can either dilute it. So Dr. Yogesh has told us no need to dilute it. He thinks that there is no role for dilution. And then he will give intradermal injections over the arm. Okay. Maybe 1 centimeters apart. So every time he draws new designs, sometimes he will draw a tortoise, sometimes he will draw a frog, sometimes it is a snake, whatever. But he does it that way. He likes to draw those designs. Then the patient clicks photos with him. Everybody is very happy that something must has happened inside their hand. After this happens, you normally wait for 4 to 6 weeks and you allow body's response to develop blocking antibodies. Should you be very focused and document and you want to get a Lancet publication out of it, then you should repeat a CDC cross match. Okay, ke bhai ho gaya hai. Okay. He does not recommend us to do that. So honestly, we have not done it over the last 150 patients at least. Okay. 100 patients, so I'm sure we have not done that. Okay. So what typically happens is after that, after 2 months of this therapy or 1.5 months of this therapy, we ask the patient, "Ke kaam karo, try karo naturally. Any which ways, all your other factors are good. Everything has been tested. Blocking antibodies are formed. Aap log naturally try karo." You can give Sachin Dalal's letrozole protocol. It works beautifully. Extended letrozole if you want to give, I normally give it. But the great thing what we see in patients whom it works, see what people do, they do LIT therapy and then ask the patient to take prophylactic dose of heparin. They give LIT therapy and ask the patient to take 24 different types of progesterone. Okay. Trust me, if the LIT therapy has worked, I'm telling you from the bottom of my heart. Okay, then the patient does not even require heparin. The patient just requires that low dose ecosprin, that 75 mg baby ecosprin, what is available, that. And the patient requires any one form of luteal phase support, which we normally give as Dufastone. Okay, we have not changed the brand. Many biosimilars are available, but we have not changed it. Okay, so we give Dufastone and ecosprin, and the patient will go till 35, 36 weeks beautifully. Okay, that is LIT therapy. If you have done LIT therapy, time pass, and you are giving heparin to the patient, no. And if you are saying that I heparin dunga so that spontaneous abortions do not happen, 60 mg I'll give. Maybe if you are scared, you can give till cardiac activity. Okay, but after cardiac activity, trust me, even we stop giving. Okay, even we stop giving it. Okay, and that is a very, very important take-home point for all people who wish to practice or all people who wish to implement this therapy in their practice. All right. Now, apart from this, what is important to understand? What is the role of LIT in recurrent implantation failures in IVF? Okay. See, honestly, if you ask me, okay, it has got no role. You must ensure to do LIT when a patient has had genetically normal embryos tested through PGTA 2 times, which has failed. Okay. And endometrium is normal. Everything else is normal, probably then. So I don't really use it for implantation failures in IVF at all. There are so many other superb therapies which are available for that. I don't really use it for that. I don't think it has got any benefit in that situation. That is more like a marketing. There is nothing else. Okay. The good thing about this LIT therapy is, see, the intradermal injection which they give, no, in the arm, in the forearm, it will cause that little swelling, like that bleb sort of a thing to occur there. Okay. And there is no reaction also. you will see we don't give hydrocortisone. Huh? We don't give antibiotic dose or nothing. We give nothing. Okay. Trust me, when it is happening it normally happens in my hospital on Thursdays. Okay. And normally we will have 5-7 patients together. Everybody's chatting with each other. And everybody's chit-chatting with Dr. Yogesh. Okay. When that is happening. So it is really good. And I want to now, before I conclude, tell one bad point. Even after LIT therapy, if somebody is going to abort now, they may abort. Okay. Because this therapy out of 100 will benefit maybe 15 to 20% of the people. Okay. Do not think that despite following such strict criteria, also it benefits 100 on 100, because I personally think there are going to be so many other factors which are going to, which are going to affect the implantation of pregnancy and the outcomes. Okay, so many other factors. So I personally think one has to be cautious. We still take consent of this therapy as an experimental therapy. We do not take consent of this therapy as a proper therapy. This still gets to be considered as an experimental therapy consent. Many people will sign for it because many people are unaware and they just desperately want a solution. Okay, many people will sign for it, but we take consent as an experimental therapy only. Okay, I hope this brief lecture, which we normally try to do on Mondays of around 20 minutes, probably has helped you clear a good amount of concepts, maybe 2 or 3 questions, and rest of the questions we are going to answer on WhatsApp. So,
can I ask something, Dr. Jain?
Yes, please, madam.
Yeah, you said this LIT therapy will not benefit of RPL. So while choosing itself, can't we choose those patients of RPL who have immunological causes for RPL? Without, don't include the genetic ones or those with uterine.
Difficult. See, honestly, yes, definitely. That's what I said. Your pre-evaluation, 3D ultrasound, if the anatomical problem is present, don't do LIT. That's what I'm saying.
Yeah, don't do. Yeah, so it's unindicated.
It is to be only done when, as I mentioned, male factor and female factor, everything is normal.
Only immunological RPL. So that's the take-home point, that LIT is indicated only for immunological RPL.
I agree.
What is the approximate cost for LIT?
You want to know the pan-India charge, or you want to know my charge?
Not at your clinic, generally all over India, what people may afford.
See, I guess there are some people who are doing it for maybe 60,000 rupees also. And that is what at least I've heard from a patient, from at least 5 to 7 patients who have miserably failed LIT therapy because they were told it is going to work 100%. And after that, they've had 4 IVF failures with donor oocytes. So all these things keep on happening. At my place, I am a little expensive, so we normally take 1,30,000 rupees for doing the therapy. But then, as I said, I'm any which ways on the higher side at everything.
So you recommend it for recurrent IVF failures, plus you also...
No, I don't. I don't recommend it for recurrent IVF failures. I only recommend it for
implantation.
Recurrent spontaneous abortions of idiopathic origin. Okay, where male partner and female partner are banged normal.
Okay, great. So it's something new, which we are thinking is new. Actually, is there since a long time. But we have come to know of this because more and more of IVF is coming, more and more of implantation failures are there, and more of this LIT is being talked about. So thank you so much.
In IVF, honestly, in IVF, see, a simple thing to do in IVF before you do LIT, or even if you think of LIT, is simply to do PGTA. Okay, simply do PGTA. Okay, and come on, if I to finish this in one line, no, at least in Maharashtra, if a patient is going to do 2 IVF cycles with self eggs, and if it is going to fail, 5 IVF clinics are going to convince him for doing donor oocytes or for donor sperms or whatever. And in that situation, you don't have any indication for this therapy. Yeah, Kiran sir, you wanted to ask something. I just want to unmute you because your hand is up.
So there are a lot of questions in the chat box. That is why I thought that we should address to them, because we have over 320 participants. That's really a big number. So,
That's
Oh.
SSR.
yeah.
And
So,
that too SSR.
yeah. What is your advice if there is CDC incompatibility?
The CDC cross match. So
Yeah.
see, when the CDC cross match has to be negative for you to do it. Very rarely, if it is indicated, we will also go ahead and do an HLA typing. And HLA typing difference has to be more than 2. If the difference is less than 2, it indicates that they are compatible. There is no indication for doing this test. But HLA typing, again, we do, I learned a bit of this from Dr. Padma Priya, obviously, who is doing HLA typing very frequently for uterine transplants. And also from Yogesh Bhai, because he does a lot of HLA typing and he does bone marrow transplants. So we learned a little bit of that from them. So, but they don't routinely do it. Just to give you an example, HLA typing for the couple is going to cost you around 13,500 rupees.
Okay.
So it's expensive. It is not something which is less. CDC cross match for the couple is 4,450 rupees.
Okay. Is there any specific license which is required for your institute?
No.
To do this thing?
No.
Can it be carried out in small nursing homes also?
I don't know that. Best is to speak to Hitesh Bhai, our medical legal lawyer, for the licensing work. But it doesn't require. See, there is always a difference. See, I have my own pathology lab. I have my own genetic lab. I have my own microbiology lab. I have my own cold room. So, I mean, whatever you ask of, I have. Correct? At this point in time. I don't know if it is right or if it is ethical to practice it, or you are medico-legally safe in practicing it in small nursing homes. I don't know that, honestly. Best is to take your detailed consent. Our consent for LIT is 8 pages. The amount of time we take for processing, na, utna time lagta hai patient ko consent padne mein. And we have had patients who have told us that we don't want to do it. No problem. Husband का खून वैसे भी wife पीने वाली थी, योगेश भाई 100 ml पी गए, कोई फर्क नहीं पड़ता यार. You know, they walk home happily. That no problem, we don't want to do it, we are scared. That is common because people have this expectation. See, in India, when people pay money, they have this expectation that the therapy has to work, right? And we've mentioned it 4 times on our consent that it may or may not work. Okay, 15% is the chance in best cases.
Okay. Well, that was one of the most simplest and most easiest way for you to explain to everyone. A lot of us are hearing about what is LIT यानी क्या है. So LIT stands for lymphocyte immunotherapy. ये भी question किसी ने पूछ लिया है. So anyway, that was a very simple and lucid explanation that you gave. Any other questions from Dr. Sarkar or Dr.
But I want to add one more point. Probably I added, but I've forgotten right now if I added it or not. See, we don't really end up checking for CD53 in the endometrium. We don't really end up looking at TNF alpha levels in the endometrium and all these things. All those things are of questionable benefit, very honestly speaking. Okay, and it has been again proven without doubt that they are of questionable benefit. Okay, so we don't really do that. I'll tell you what I do very special, which I think I told, but again, if I forgot and I'm telling it again. In all patients in whom we are doing LIT, I do a office hysteroscopy. Okay, trust me, if I'm screening, let's say 10 patients for LIT, 2 will be diagnosed as chronic endometritis, okay, with those micropolyps, heavy vascularity on the lateral wall, okay, all these things. And believe me, in them, the treatment of choice is to give Cynomycin plus Placentrex, okay. It is not mentioned in any journal. You give Cynomycin and 20 days of Cynomycin, 20 days of Placentrex. Khatam. Within 3 months, the patient will come to you with a beautiful, spontaneous conception like she has always had. Okay. But we post this therapy. The beauty is this pregnancy will go on nicely till 36 weeks. Kuch dene ka zarurat nahi padta hai. But you must diagnose chronic endometritis, which we see very commonly in India, which is not seen in other countries. which is what I think I do for all patients. Okay.
Yeah. So do you repeat the dosage again during pregnancy or before the heartbeat?
If more than 5 abortions are present, the rule is to give it at yolk sac one more time when you see the yolk sac.
Okay.
And you said
But in
that
my opinion, it has got no role. So that is what we have been discussing many times. So see, remember, as again, what is this therapy for? This therapy is to stimulate production of blocking antibody. Correct? Now, once that first IgM cell is developed to form that blocking antibody, no, the amount of IgG response which you can develop the next time if she conceives with the same partner is unbelievable. Okay, is unbelievable. Okay.
So have you seen having successful pregnancy subsequently also with one time LIT therapy? So does it
So
work for the rest of their life?
So I am yet to see after 3 and 4 abortions when they have the first child, no, what I have seen at least. Okay, I am only 7-8 years into practice. So we started LIT only 3.5 years, 4 years back. Okay, so in that situation, our first person who delivered post LIT delivered sometime in 2021. Okay, after getting pregnant. So we are yet to see them come back for a second pregnancy. So I am not the best person to answer that.
So theoretically, I think, I mean, what you say that the blocking antibodies, if conceived with the same partner.
Yeah, see, you don't need LIT again. Remember, once that blocking antibody is formed, no, it's like this. Once you have toxoplasma infection, first time, you will never have it in the rest of your life because IgG response is so powerful. Okay, same thing is with blocking antibody. This LIT is to form the blocking antibody. People somehow don't understand that point.
Okay, Jay, there is one more question. Can you repeat the treatment for chronic endometritis?
Cynomycin 100 mg 20 days OD, Placentrix IM 20 days.
I think that should start. Well, at this point of time, I think we should welcome our overseas delegate. I mean, I should be very happy to tell you, Jay, that you have fans outside India also. So welcome Dr. Fahmida Chaudhary, who is the Associate Professor.
Oh, she is in Bangladesh. She is so well known.
Yes. So welcome, madam. I mean, I can't see her, but I mean, if she hears us, I mean, she's most welcome. And I think you should now create a link for Bangladesh also.
Oh, we have a Bangladesh group of 1,000 members. We already have it.
Oh, lovely. Fine.
So great. I think thank you so much.
Thank you.
We will stop the live here.